Welcome to the presentation by our students. Our next presentation is on compression device for medical imaging, and the presenters are Rachel Watley and Ryan Williams.
Okay, good morning everyone. I'm Ryan Williams and this is my partner in crime, Rachel Watley. And we're here to discuss abdominal compression in medical imaging. With us today is also our mentors, Dr. James Johnston and Dr. Dale McDonald. And Rachel will take us through the problem.
So the rise in obesity is becoming a problem with radiographic dose in the clinical setting. And our issue is that the thicker the part, the more mass is required to image it. And so what we are trying to do is use compression to reduce the thickness of the part and therefore reduce the mass and therefore reduce the dose. As radiographers, it's our duty to reduce as low as reasonably achievable, and we feel that this compression device goes a long way in being able to do that for those patients who are 100 pounds overweight or more. Last fall, we developed and tested the compression device you see before you. And while it might look like a evil torture device, it did serve as proof of concept design and was built on a very limited budget. Using Pixie, who you see here, she's a real bone phantom and she's cast in tissue equivalent. We were able to get a baseline for the technical factors necessary to get a radiograph on her as a simulated sthenic patient, where that would be the average patient. In order to simulate an obese patient, we were able to obtain superflat, which is commonly used in radiation therapy, and take both compressed and uncompressed images. And what we saw when we were able to do that was that we got a 44% reduction in mass from the uncompressed image to the compressed image.
Okay, so on the projector right now is the initial design, just the initial prototype on paper that we sketched, and we went through, tried to figure out what exactly Dr. Johnston wanted. Dr. McDonald and I sat down, tried to figure out exactly what they wanted. Because it's a collaborative effort, they wanted certain things that maybe could not happen in engineering world. So we had to sit down and come up with the perfect design that would work for the application. Okay, so this is our original design. As you can see here, it's just pieces of wood, all thread, bolts, wrought iron. The welding was done by Dr. Johnston himself, which is pretty cool. The plates use acrylic, transparent, so the images could be processed through the acrylic. And as you can see, it was a crude version, and it's what we use for our budget. So because of our budget, that's what we were able to come up with. But it proved the concept and it worked, so thumbs up for us. And Rachel will talk about the imaging.
These images are taken from our initial lab testing. On the left, you'll see the sthenic simulated patient. We used a 68 kVp and 32 mass, and that would be about average. The hypersthenic patient, we had 68 kVp and 250 mass, which is over 600% increase. But when we were able to compress the image, we were able to decrease the mass to 140, which, while that is not as good as you might get with a sthenic patient, it is a 44% reduction. Much of our lab time is spent testing materials. On the left, the images from radiographic testing of Macrolon polycarbonate that I conducted at United Regional. Because Macrolon has bulletproof properties, we wanted to be sure that it was radiolucent. I tested the Macrolon using a real bone phantom hand from the MSU laboratory. And I was able to see bony trabecular pattern. You might have to get closer to see it, but I was able to see bony trabecular pattern in the macrolon sample. It is radiolucent and resistant to shatter, so we will be using it in our clinical prototype.
Okay, and on the picture on the right, that's me doing testing on the Superflab, which is the synthetic fat, per se, that we use on Pixie. And because it's not real human fat, it didn't act as human fat, so it was hard getting it to compress. The stiffness of it, the test you see here, we're trying to get the stiffness of the Superflab, basically, because we need to know with how much force we put on the Superflab, how much would it displace. But as I said, it didn't quite exactly act as human fat, so we had to lubricate it with dishwashing liquid and put it in a garbage bag. We had to get creative and apply the force and see if it would compress. It actually did compress more because it had less surface for it to stick to. So that's the testing I was doing in this picture. And well, for 2014, our new developments, we created a master machinist, which is Roy Johnston, Dr. Johnston's brother, which is just perfect because now we have someone close to that we could collaborate with. And now we're building our first prototype that we're going to use in clinicals. And also we tested the materials, as Rachel said. We're now using Macrolon, which has bulletproof properties. It's shatterproof, just to be more precise, which is great for in a clinical setting. In case anything goes wrong, there will be no shattered Macrolon anywhere or shattered acrylic anywhere. And also we discussed and tested handles. With making the device, we needed it to be comfortable for a tech to use. So we had Rachel go into the lab in engineering in McCoy and just test out different handles. It's a really easy way just to see what she liked, what would feel nice. And we just use her as a standard. We know different techs would like different things, but if we could get something that's kind of common for everyone to use, that would be nice. And clinical testing.
In preparing for the clinical trial, most of this semester has been hurry up and wait. We did ethics training over the winter, and we evaluated how we were going to collect the data, and we evaluated our consent form, which we were able to get Dr. Dean to help us with on the contraindications. And then we were able to submit for IRB approval, and then we were approved. We have submitted a grant to ASRT. We are revising that grant, still working on it. And the medical education committee at United Regional is set to meet on June 6th. So we are hoping to be on their agenda to start the clinical trial at that time.
Okay, so this is the new design that we came up with for this year. Basically, it's a power screw. It's a shaft with a threaded shaft. And there's two. There's a vertical one and then there's a horizontal one. And the horizontal one is the one that's going to have the handle. And basically, how it works, by turning the handle, you move the plate. The top portion, when you move the handle at the top, you move the plate up or down. And for the bottom portion, you move the whole system. The plate does not move, but the whole system moves. So you would crank the device, and the top plate will come to meet the table. You slide it, and then you use the top portion, the top handle, to bring the plate down to make contact with the human. So that's the design we came up with. And also right here, I just needed to emphasize this. It's basically a bolt, as you will see in the next picture. It's a bolt sandwiched between two plates, and this is just to help with the guiding of the plate, so there won't be any back and forth movement, but it'll be stable going up and down, which is key for the device. This is the bolt I just talked about. This is the bolt that will be sandwiched between the two plates. Here is the threaded shaft. That's one of them. Basically, both of them is going to be the same thing. The top portion is just a replica of the bottom portion, but the bottom portion is just shorter. just another picture just to demonstrate. Right now, this picture, it shows it outside, it just so everyone can see, but this bolt is eventually going to be sandwiched between two plates right here. So there's going to be one plate, this is the plate I'm talking about, the metal plate, it's going to be sandwiched in between. And there's going to be another one on this side, and the bolt is going to be sandwiched in between. The threaded shaft is going to be running through the middle of the device. And there's going to be, we're going to obviously block the screw up so you won't see the inside working. So the patients won't be scared seeing all this metal shaft with thread and things going through and all that. So it'll be blocked up. And well, before clinicals, obviously we have to do testing because as engineers we have to make sure our device works as it should and that we won't have any mishaps in the clinical trials. So we have to, because it's a unique design by Roy Johnston, we have to calculate the gear ratio, which is simple as we might go and turn the handle 5 times and see how many times the vertical power screw turned, which is pretty simple. Engineering is not that fancy. Finding the force applied, because we need to know what force we're applying to these patients. Because we don't want to, we're aiming for just a small chest on your stomach. We don't want to apply a grown human sitting on your stomach. So we need to know what force we're applying to the patient. And also the torque, we need to find the torque in the handle when turning, so the tech would know how much to crank it down, how much to crank it up. And Rachel will talk about the clinical part of it.
Once we have our clinical prototype, we're going to need to repeat the radiographic testing that we did with our initial device. We'll do that using Pixie and the SuperCloud. Once we have data from there, we'll be able to do personal testing of the device. I called it first. And then we'll evaluate the device for ease of use. And that will involve not only my use, but getting maybe some techs to come in and see how they like to handle or whether the height is okay, if it's too hard to push around, that kind of thing. The clinical trial, we're hoping to do in cooperation with United Regional. We are here to test the device on human subjects, and we have started collecting data for previous uncompressed exams at that hospital. We'll compare the new compressed examinations to previous uncompressed examinations to get an idea of how much of a reduction we're getting for each millimeter or centimeter of compression. And then we'll import all of that data into SPSS.
Okay, so we're planning to investigate the use of Arduino to update the compression device with LED displays and different warning lights, just so the tech would know how much force is being applied. And if something is going wrong, they'll be like flashing LEDs just saying, hey, stop the compression. We also plan to find a relationship between the RPM and the angular velocity in the handle. Also, we're thinking about changing the position of the handle, because basically right now the device is about 4 to 5 feet tall, so the tech will be up here cranking. So we want to make it a little bit more comfortable for them, where the handle will be maybe here, so it'll be comfortable and their arms will be hurting all day cranking this device down. So we'll be looking at that, and also we're applying for a patent because it's a unique design. It's something that could basically be very helpful to a lot of hospitals around the world. We want to make sure we patent it because it's our idea and we want to protect it. So we're applying for a patent as well. And this is a picture of the Arduino board that I was just talking about, which is just basically you plug it in to the computer, and this is what we're going to use to get the LED display and the different LED lights, the warning lights and everything. You program this, and this is what we use to get the different displays and everything that the tech, like especially values that the tech may need to see, like the force and other important values. And our acknowledgements.
We wanted to acknowledge Roy Johnston for building our clinical prototype. Dr. Salim Azouz consulted with the team regarding equations of motion, transmitted force and torque under zero and constant velocity. And Mr. Mark Weller mounted acrylic plates on the prototype you see here and also suggested Nacrolon as an alternative. We'd also like to thank Dr. Johnston and Dr. McDonald for guiding us academically and professionally. They have spent many hours answering numerous questions and emails during this past year, and we're so grateful to have you guys as our mentors. Thank you.
This is just a list of references.
Rachel,
Any questions?
what is the cost of this acrylic?
The-
Is bulletproof? Is that?
Oh, no, the
Macaron.
Macaron.
Mhm.
We looked at it, but I'm not sure the exact price. I'll have to look at it again to give you the exact price. I don't want to quote anything that's not true.
Okay. And then, you're talking about the PSI is what you're going to be using. Is that based on patient comfort?
Not PSI, basically the
Okay.
force being applied to the patient. You're asking if it will be comfortable for the.
Well, when will these LED lights and so forth?
Hopefully as soon as possible.
I know
Our
that-
goal is
Oh, you-
for
oh,
it to
you
be about
mean-
25 pounds.
I get what you're saying. It will, when as soon as it crosses that, the LED lights will flash and say, "Hey, you're applying too much force," because we need to stay within that range. As I said, different people, different fat on different people will have different stiffness. So some may compress more than others. So we don't want to go based on distance, but we want to go based on the force being applied to the
So
patient.
will we be asking the patient? Then is it the patient? How
The,
much?
the patient will have a say in it because, I mean, at the end of the day, we're using it on them. So if it's too unbearable for them, we'll have to take off some of the compression, which would mean probably more radiation. But the LED lights, the goal is to have a LED display that will tell you how much force is being applied. So we'll know exactly how much force we're applying. So we'll never go over that that standard that we have, the 25, 40 volts. Any more questions? Yes.
Yeah, actually, I had a couple of different questions, so
Sure.
whatever order you want to answer this in. Do you have any past devices that use compression for X-rays or any other methodology that's been used in radiography for compression?
Yes.
Compression has been used in mammography for years, and there is some research involving compression of the abdomen using straps. This is the first device for the abdomen that uses 2 points.
Okay. My second question had to do with, in order for you to get your readings or reduce the amount of X-ray exposure, does it have to be evenly distributed, the force? Because the way that it's set up over there, you have
Oh,
the 2 on one side
Right.
and then nothing on the other side. So I was just wondering, would you be
Yes.
benefited by having something compressing on both sides?
yes. We did put the strap on back in the testing. Let me see if I can get
There's
that.
a picture.
Yeah. But yes, it's supposed to be evenly distributed.
Okay.
Just this time we didn't put, as you can see right here, there's a strap.
Okay.
It looks more even in this picture. As you, yeah, we didn't put the straps on just because we're just showing off basically the device. But the new device that we're building is going to be strong enough where we wouldn't have to put a strap on. The only reason that we put a strap on this one because there's a buckling effect being created right here. So we had to put a counterbalance basically just to even off.
Why not have like this ratchet system, if you will, on both sides?
Why not have
Yeah,
it
why
both
not
sides?
have this like the?
Because the tech,
this-
Rachel will be able to tell you better because of how the room is set up, right?
It wouldn't be practical to get on that side of the patient and have to crank anything down.
Got it. Okay. Okay, I see what you're saying. And also my last question had to do with, when you actually do this on clinical trials with human subject, what differences are you anticipating or expecting because you're dealing with real human lab instead of sleep lab?
Well,
That really depends on the patient. With men, you'll notice that when they lay on their backs, a lot of times their adipose tissue does not displace like it does with women. So each patient is an individual.
Pure fat versus chocolate fat. I'm kidding.
Got time for maybe one more question.
If you're compressing it, you're gonna get more, you need to get more of a uniform picture of these patients than as opposed to what we're
Yes,
doing right now, where it
absolutely.
fades off on the outside edges, so they're gonna be able to get more diagnostic reading from these images taken with compression changing these patients.
Yes, and I'm after small valve, or small valve Hollander, when we're looking for that ileocecal valve, maybe we won't need spots. I don't know. I'll have to see when we get a sample how that'll work.
Great, thank you very much.